I'm David Brown, Director of the Virginia Department of Health Professions. Welcome to Virginia's core competency modules for pain management and addiction. These competencies were developed by work groups convened by Virginia's Secretary of Health. Over 24 experts in pain management and addiction compiled the essential competencies that Virginia's health professional students must acquire, not just our future physicians, nurses, dentists, and pharmacists, but the wide range of professionals who work with these types of patients. These modules, made possible by a Department of Behavioral Health and Developmental Services grant, present key parts of the competencies for use not only by our schools, but by practitioners already in the field. Thank you for your careful attention to this important information.
In this section, we'll discuss evidence-based treatment models for the treatment of opioid use disorder. The setting of care for addiction treatment really runs the gamut from specialty addiction treatment centers to general medical hospitals to community-based primary care clinics. We'll only cover a sample of these programs. And although diverse, at their core, most of these programs have just a few key components, including pharmacotherapy, care management, psychosocial treatment services, and education and outreach. The first program we'll talk about is one we already referred to in the past. It's the Opioid Treatment Program. The Opioid Treatment Program, or OTP, as you may hear it called, is a federally regulated, typically outpatient clinic that is able to prescribe and dispense methadone to patients. These programs were a direct consequence of President Nixon's war on drugs and during the 1960s and 70s, rapidly expanding access to care. In addition to providing methadone, they often provide buprenorphine and naltrexone. These programs have strict requirements and are highly structured treatment programs. Often, patients must come in daily for supervised dosing and dispensing of their methadone treatment. If they fail to show up or relapse, there may be consequences. In either their treatment is intensified, which would be good, or unfortunately, they may even be discharged from the program. In the community, these programs are sometimes called methadone clinics, and methadone carries with it tremendous stigma among patients, providers, and community members. Some refer to methadone as liquid handcuffs, and part of this has to do with the really tight regulations and highly structured programs that lead some folks to call it reminiscent of a correctional setting. However, one important thing to know is that this is the only place you can get methadone. And methadone, and sometimes the very highly structured environment can be very therapeutic and beneficial for patients, especially those with chaotic social lives or very severe opioid addiction. The next program we'll discuss is the Office-Based Opioid Treatment Program, or OBOT. This program was made possible by the Drug Addiction Treatment Act of 2000, DATA 2000, which approved the prescribing of buprenorphine products for addiction by clinicians who completed 8 hours of approved training and submitted a waiver to the Substance Abuse and Mental Health Administration Agency, or SAMHSA. The legislation was a game changer and expanded opioid agonist treatment beyond the confines of an opioid treatment program, which had limited slots. And so any prescriber, including now physician assistants and nurse practitioners, can, with the right training, prescribe buprenorphine in the office-based setting. I'll highlight two models in particular. One is Virginia Medicaid's preferred office-based opioid treatment model, and the second is a model that really developed in the Pacific Northwest from the University of Washington called the collaborative care model. Compared to opioid treatment programs, which are again highly structured and federally regulated and can prescribe and dispense methadone, OBOTs, office-based opioid treatment models, have a lower threshold to entry. They have less restrictive policies. They offer buprenorphine and naltrexone, but not methadone, and are often integrated with general medical, specialty infectious disease, or psychiatric care, which really helps reduce the associated stigma of addiction treatment. In addition, They share a focus on care management and regular interdisciplinary team meetings. The Virginia Medicaid's preferred OBOT model is person-centered and trauma-informed. The journey to recovery can be tumultuous, uneven, and patients frequently face stigma. Therefore, the goal of the preferred OBOT model is to provide an experience of care with a low barrier of entry that aims for retention and long-term recovery. And so the preferred OBOT model, and what we do at Virginia Medicaid, is we're trying to incentivize high-quality, interdisciplinary, team-based outpatient care for opioid use disorder. The preferred OBOT requires co-located behavioral health, ongoing assessment for the need for behavioral health services, a patient-centered approach, tight linkages with medical care, and really aims to provide comprehensive specialty level care for those with opioid use disorder. 2 additional points. 1, while behavioral health services are co-located for preferred OBOTs and should be offered as needed, the preferred OBOT model does not require patients to accept services as a condition to receive life-saving pharmacotherapy. And so again, while they should absolutely be offered, and providers should do everything they can to make sure that patients are getting the best care, which includes behavioral health and psychosocial treatment services, if a patient for some reason does not want it or cannot access it, they're still able to remain on and receive life-saving pharmacotherapy. Second, relapse to opioid use is a common occurrence in the care of individuals with addiction. Providers in our model, they should not discharge patients based on relapse and/or positive drug test results. When they discover relapse, they reassess a patient's condition, their adherence, their dose of pharmacotherapy, and the modality of psychosocial treatment, and consider intensification of care, including possible referral to a higher level of care. The collaborative care model has been used for multiple conditions, including alcohol use disorder, chronic pain, depression, anxiety, and many other conditions, and is evidence-based. In this model, an addiction specialist reviews a patient registry each week to make sure patients don't fall through the cracks. The care coordinator, which is really central to the collaborative care model, helps maintain the registry. They may set up future appointments, promote community-based mutual help groups, and follow up on other types of conditions like depressive symptoms or cravings. The addiction specialist provides guidance to the care coordinator around patients' relapse and around MAT, and supports the primary care provider their prescribing of medication-assisted treatment. One important thing to note is the collaborative care model is really it's really centered around the patient and around the primary care physician. And so this model is dependent on a primary care physician being willing to prescribe the pharmacotherapy with the assistance of a care coordinator and a consultative addiction specialist. So the most important element that guarantees the excellence of care is really the interdisciplinary addiction team. Over time, medicine in general and addiction in particular have started to recognize the importance of an interdisciplinary team of individuals with diverse training and background who can approach and meet the patient's needs in a comprehensive way. So really the team is made up of at least 4, if not more, individuals. First is the prescribing clinician. Because pharmacotherapy is so important, a clinician really should and must have completed the 8-hour training to receive the waiver to prescribe buprenorphine. And they should also offer naltrexone, both the tablet version and the extended release version. Notably, the prescribing clinician can be a physician, a nurse practitioner, or a physician's assistant. The second really key component of the interdisciplinary team is the behavioral health clinician. This is someone who really focuses on the psychiatric, psychological aspects of care for the patient. They do a comprehensive assessment, and they provide therapy or help to coordinate therapy for individuals who need it. The care manager. Absolutely, this is someone that is necessary for the addiction team to function well. And the care manager, really helps, as you can see with the collaborative care model and the preferred OBOT model that we just discussed. They are involved with bringing the team together, coordinating the various aspects of treatment that are necessary for successful recovery. They focus on making sure the patient has access to their medication through insurance and pharmacy. They make sure that they are accessing psychosocial treatment. They make sure that their family is involved if the patient wants to. And they connect them with needed social services, whether that's housing, food, or transportation. I think finally is that in many ways, they're often the ones that are responsible for communicating with the behavioral health provider and the prescribing clinician. The last, I think, really key team member is the peer recovery specialist. So in the preferred OBOT model, the peer recovery specialist is optional, but the best models are ones that include peer recovery as part of their team. And the function of the peer recovery specialist is really recognizing that every patient comes to care, presents to care at a different stage of readiness with different life experiences. And the point of the peer recovery specialist is really to meet patients where they are, whether that's engaging with them in the community, in the emergency room, in the inpatient setting, in the correctional setting, engaging with people, building trust, helping to really lower the barriers that are often put up between folks with addiction and society. Barriers that include stigma, that include lack of knowledge, that include even logistics of, okay, where do I get access to care? And so, the peer recovery specialist is extremely important. And one thing that I want to mention is that the peer recovery specialist often shares a background, whether that's a socioeconomic, a demographic, or even a background of addiction with the patients who they're caring for. And then the last sort of team member that could be very useful and is, again, optional in the preferred OBOT model is the clinical pharmacist. Now, the clinical pharmacist, depending on the model and the team, can serve a very pivotal role in making sure that a patient is optimized on their pharmacotherapy. It can really coach them and monitor their symptoms, whether that's during the induction phase or whether that's once they're already on maintenance but might be experiencing cravings. So these are the really core elements of the interdisciplinary addiction team. So once you have your team in place, what are the characteristics that make that team effective? So you have all of the right people at the table, but to make sure the team is effective, it takes more. It takes a focus on culture, communication, and ideally, co-location. The culture piece is essential, again, because addiction is such a stigmatized disease, and it can be challenging to care for patients who might have chaotic social lives and who have a chronic relapsing disease that addiction is. And so mission is critical, that everyone on the team understand and believe in the mission. Having policies for when things go awry, contingency plans, cross-training so that the behavioral health clinician knows about pharmacotherapy, the prescribing clinician knows about behavioral health, the peer recovery specialist understands the intricacies of care management, and the whole team understands from the peer recovery specialist really what it means to have a lived experience of addiction. The final part of culture is community outreach and education. And this is kind of taking the principles of cross-training and bringing that to the community, to other providers, to pharmacies that you might interact with, to mutual help groups like Narcotics Anonymous. Really the point of this, again, is focusing on the stigma around addiction and really bringing people into care wherever possible. The second is communication. Communication is essential for any team. The number one most important thing is having regular meetings And in both the collaborative care model and the preferred OBOT model, the care manager is responsible for those meetings and bringing people together. And at those meetings, they share data on how patients are doing, regularly monitoring them, making sure that they're getting the care they need. So regular meetings, data, and a platform for communication. And in most cases, that's an electronic medical record where the team can communicate with each other seamlessly. Which brings me to my next point, which is co-location. While not a requirement to have an effective team, in our experience, co-location is critical to developing a culture, to streamlining communication, and providing excellent care to patients with addiction. One of the principles of high-quality addiction care is making sure that every door is the right door, wherever patients are, whether that's in a jail or prison, parole, probation, a homeless shelter, an emergency department, a hospital, a psychiatric facility, a primary care practice. Wherever they are, every door is the right door to accessing care and starting the journey towards recovery. And the good news is that we are now starting to have evidence that this approach of making medication-assisted treatment available throughout the community, wherever people are, really meeting them where they are, is effective and can be life-saving. So I wanted to share two studies with you. One is they took this idea of every door is the right door and really thought, okay, where do folks with opioid use disorder, where do they come? And two places, and I'm sure you all have answers, the folks that are listening to this. But two places that they come is they come to the general medical ward, inpatient ward, maybe with infective endocarditis, maybe with cellulitis, maybe with something else. They come to the emergency department, maybe in withdrawal, maybe after an overdose, maybe in severe pain. But most of those settings don't offer medication-assisted treatment. So in the first trial, it was a randomized controlled trial of initiation of buprenorphine versus standard detoxification of people who were opioid dependent with addiction and admitted to the general medical service. What they found was that patients who were initiated on buprenorphine were much more likely to enter into outpatient care once they left the hospital. At a rate of 72% of folks who were initiated on buprenorphine entered into outpatient care versus just 12% who were detoxified. If the standard of care for this chronic disease of addiction is community care and accessing community services over the long term, then 72% versus 12% is a success. However, it's important to notice that one of the really great things that the authors of this study did is they followed patients over a period of time. And they found that at 6 months, there were still significant differences between folks who had initiated on buprenorphine and those who were detoxified. 17% of those who were initiated on buprenorphine in the hospital were still engaged in outpatient buprenorphine care versus only 3% among those who were detoxified. So a five-fold difference, over a five-fold difference. But when you look at these percentages, talking about high individuals who are at high risk for poor health, then 17% and 3% don't seem that high. Which brings me to the next study, which really focused on the emergency department. So similar to the prior one, it was a randomized controlled trial where they randomized patients coming in with opioid dependence to either buprenorphine initiation in the emergency department versus a brief intervention, something like SBIRT, which you've heard about in the prior module, plus referral, or just referral. In the confines of the emergency department. So buprenorphine, brief intervention, referral versus brief intervention, referral versus just referral. What they found was really, in some ways, quite similar to the prior study. They found that those who were starting buprenorphine at 2 months' time, they were much more likely than those who just got the brief intervention or just got referral to be engaged in outpatient care. At a rate of 74% of those who started on buprenorphine engaged in care at 2 months versus 47% who got brief intervention versus 53% for referral alone. Interestingly, these authors also followed patients for 6 months and 12 months, and they found that there were no significant differences at these intervals. And so I just want to raise a couple of points related to this. Number one, every door is the right door. When we are able to meet patients where they are, we're able to significantly, and I'd say impressively, increase their initiation of care. From the hospital or the emergency department to outpatient care, 70+% of those initiating on buprenorphine. That's pretty good. That's one. The second thing I want to highlight is in the emergency department study, there were no significant differences between those who received SBIRT type intervention, a brief intervention, plus referral, versus referral alone. So while useful, and of course more studies need to be done, SBIRT is not enough for folks who are presenting to these acute care settings. They really need high touch, high engagement, and MAT. Really, in some ways, same-day access to MAT, in addition to the high-touch care that someone like a peer recovery specialist can provide. And the third thing I'll mention is that in both these studies, at 6 months and then the second study at 12 months, we started to see the differences attenuate and that people really dropped out of care. And in my experience, people need to be engaged in care at least 1 to 2 years, as I mentioned before. And so if people are dropping out at 6 or 12 months, it likely doesn't mean that they've reached recovery. It means that they're probably relapsing. And so this presents to all of us really a challenge and an opportunity for not only how we can engage people in care, initiating care, but how we can retain them in care, how we can have a low threshold, high retention model of care that meets patients where they are. So in this last slide, I want to continue the conversation about how we can find ways to remove barriers to care initiation, care engagement, and care retention to lead to recovery over the long term. I think that's why we're all here, is we see that there is a tremendous problem in our communities, among our patients, in our state, in our nation. And so all of us really need to think critically about how we can be part of the movement, how we can be part of the solution for helping individuals with opioid use disorder, with other types of substance use disorders, achieve recovery over the long term. How can we do that work? And I think it comes down to a few things. One is training. So the fact that you all are watching this is a first step. Medical schools, residencies, frontline providers, community members, folks getting waivered to prescribe buprenorphine. But that's not enough. Payers have to increase reimbursement and focus on high quality care. And that's something that we've done at Medicaid and that a number of other payers have started to do and I hope continue to do. The third thing is removing barriers to treatment. Like I said, and I've said many times during the course of this module, addiction, one of the hallmarks of addiction is stigma. And it is one of the greatest barriers to treatment that we face and one of the greatest threats to really ending the opioid epidemic. And so we need to think critically about how we remove barriers to life-saving treatment. And that could include, and so at Medicaid, one of the things that we did recently is we removed the prior authorization for Suboxone, buprenorphine and naloxone, up to 24 milligrams, so that people could have access to care, because we know that prior authorizations serve as a barrier. So we removed that. We did the same for hepatitis C treatment, because a lot of folks who will present with addiction may have comorbid hepatitis C. And so we're asking our addiction treatment providers to test folks for hepatitis C and HIV, and we remove the prior authorization for hepatitis C treatment and, of course, HIV treatment as well, including pre-exposure prophylaxis, which can reduce the risk of HIV acquisition by over 90%. And this is very important for a population that might be prone to relapse and sharing needles and transmitting HIV and other infectious diseases. And the last point is really this idea of every door is the right door. supporting treatment at all points of care, meeting patients where they are, and really moving towards a system that's focused on people and their needs, and meeting, and so I am confident that we can do that. And that includes making sure that there is MAT throughout the spectrum of care, addiction care, psychiatric care, hospitals and emergency rooms, primary care, that it exists in prisons and jails, that people are able to come to a homeless shelter and find a way to access MAT and addiction care. And I think if we can start with any one of these, right? We can start small. I think we'll have a chance of really doing justice to our neighbors, our community members who suffer from opioid use disorder and addiction, and start to bend the crisis in our midst of opioid overdose deaths. And so I just want to end now by, again, thanking you for your time and your commitment and your passion.